Welcome back, everyone. I love how our D team has done such an amazing job at bringing in different topics and different speakers. We've heard about A lines, central lines, dialysis, infection prevention. Boy, it just keeps getting bigger and bigger. Our next session will be presented in two parts. Part one, the impact of a vascular access team that they have reported on patient outcomes in teaching and non-teaching hospitals. A review of current research will be presented by Dr. Amy Barden. Dr. Amy Barden is a vascular access specialist with a long bio and many accomplishments, which you can read all our bios on our conference website. And part two, building a case for the need of a vascular access team in a large academic medical center, will be presented by Jonathan D'Aliso, Marissa McLean, and Kelly Zambrisky. Without further ado, welcome my friend and colleague, Amy Barden Spencer, Dr. Amy Barden Spencer.
Thank you, Judy. And thank you for that introduction. And I just want to say thanks for everybody attending day 4. I agree with Judy. It's been a fantastic conference. So if you attended a couple days ago, the arterial session, I said to you, I love arterials. And my true passion has really been in the impact of vascular access teams. And I just finished my doctorate in this very topic. So I do consider myself an expert as to John's definitions, and that's how you become an expert. But I hope to help demonstrate some of that today and talk through some of the evidence to support your ongoing advancement. So let's get started. I do work for Teleflex. I'm very proud that I do that, and we have supported vascular access expansion for over 10 years, which includes the CVC insertion course, and you heard a lot about that from different case studies presented throughout the conference. And I hope that those teams, wink, wink, are going to publish so I can add them to the repertoire of evidence to support vascular access teams. So in this presentation, we're going to look at the current state of teams, because I think that in our own profession, in our own entities, our organizations, we call ourselves differently. And many years ago, I told you from the stage at AVA, and I wish we were all together, that you aren't IV teams, you're vascular access teams. We're not PIC teams. We're holistic. We're assessment oriented. We do what's right for the patient, not always what's easy for us. And that makes us a specialist. And that's why we have retermed and recoined a lot of our job descriptions and a lot of our team efforts to vascular access specialists. We're going to review some of the team designs and how some of those have come into practice and why they've come in. And we're going to discuss new research related to team outcomes. There's a focus on the responsibility and the role, and if the role is making an impact in the clinical environment. And then we're going to review the impact on reported CLABSIs. That's what my evidence generation was for my doctoral degree. So from a team perspective, there are guidelines, as John described, whether it's recommendation or guidelines to support practice change. And some of the guidelines to support VA teams include what's listed here. So the Centers for Disease Control really said specialized teams, right? Specialized teams with the effectiveness in reducing infection, complication, and cost. We have to think about that. So if we have specialized teams, and there's a lot of different types of teams in healthcare, they have to have that goal in mind. It's not just a team of people who love to work together, but it's a team of people that are impacting the patient outcome and being a core portion or part of the healthcare delivery system and team. That team is also recognized by interpersonal teams within the hospital, such as infection prevention, risk, or quality. And that team also then should have a seat at the table in which those decisions are made, whether they're product or process or resource. And I just want you to think about your own team as I go through this presentation and just pepper in some of the contributions, but some of the attributes that we should have in our team dynamics, and some gaps that we might have too, that we might want to seek to fill. The Institute of Medicine, the Joint Commission Agency for Healthcare Research and Quality, also recognize the importance of teamwork, right? The teamwork that improves healthcare overall in a holistic manner. So teamwork within that team metrics with those identified workflows and processes, again, substantiating a reduction or an improvement in patient outcome. Several agencies also have recognized the benefits of teamwork and have prioritized it as a recommendation for improving healthcare. INS, the latest standards, 2021, organized a team of clinicians dedicated exclusively to infusion and vascular access practices to provide optimum method of infusion delivery in acute facilities. I would weigh into that we reach now beyond acute facilities. In acute facilities is where we're seeing a lot of the reporting, a lot of the metrics, and a lot of the early insult to patient outcome. But the continuum of care, when we make those decisions regarding the care continuum, should be justified by that team inserting those devices as to where that patient's going to reside in the end. Again, bringing that teamwork, that team framework, and that reduction in complication aspect into the picture. And then the AVA position statements that you all are very aware of now that support vascular access specialist teams and other qualified clinicians to be that really that primary stakeholder when vascular access is required within your organization. And really a message of first do no harm. We've heard this a lot. Different companies now are using first do no harm. We're very comfortable with the statement, but how does that apply to us in our specialty? So first do no harm is really related to the education in which vascular access teams have training education to onboard them and to maintain education. So you're not educated once, you're educated on a continuum, especially when there's evidence coming out almost on a daily basis regarding some aspect of vascular access. We've had a lot of great work done in vessel health and preservation by Nancy Trick and Nancy Moreau, and really that is the foundational groundwork. We should be well versed in vessel health and preservation. Device selection should not be limited to what's within our reach, but should be expanded to what the patient requires. So we should be that advocate, that conduit to the healthcare organization to justify and to establish a precedence as why another device would be needed, or maybe some devices need to be limited. Policy supports what we do, right? Again, foundationally, if we don't have policy to support our clinical practice, or policy to substantiate our team, or policy to improve patient outcome, none of those can be achieved. And with the new INS standards that just were released recently, a lot of your policies should be revamped to reflect those and any changes in which those guidelines suggest or support. Certification, if we were live, I'd all have you stand up if you were VA/BC, and if you want to raise your hand and be very proud, I'm very proud of you. Certification puts not just your organization team in the limelight, but also AVA and vascular access together. Um, and then quality improvement, this is like the circle of what we do, right? So quality should know who we are. We should know who quality is, but we contribute to a lot of which quality is trying to risk mitigate within healthcare organizations. So these are quality really is a key stakeholder in our body, in our plethora, in our data collection tools, etc. Quality should have eyes and should not be surprised at the efforts in which vascular access teams are supporting. Complication avoidance, again, first do no harm. We try our best to risk mitigate. All of our guidelines and standards and recommendations, regardless of what we call them, all ask that we reduce harm to patients and do the least invasive opportunity, but also do what's right for the patient, regardless of the order that we get. And sometimes that takes big, broad shoulders and a big voice from your team. Again, unity is essential in this approach. And then procedural competency. I'm super excited for the ACE program coming from AVA. As the president of the foundation for AVA, this really makes me excited that there's a resource now for teams that are seeking the fundamentals of vascular access, but also advancement in care to their patients. So procedural competency is the first and foremost, and we don't unlike Casey's team does the exact same competency and credentialing that a physician team does. Not a lot of hospitals do that. That might be a great model. And Casey, it would be such a good project for you to publish on. But things like that, we need to be stronger and be aligned with what other competencies are having to be done by other types of clinicians performing vascular access. So Davis et al. In 2016 recognized vascular access as high volume, high risk invasive procedures, right? So these procedures impact patient outcomes if the appropriate training is not achieved. Dr. Alexandro emphasized that a centralized vascular access service with a small number of specially trained personnel may be more important than the procedural success than clinician grade. And that basically says that as long as a clinician is doing the procedures routinely, and they're a small group, meaning you start small and you grow your team, that the title of the clinician isn't as important as their competency and ability to perform the task. Very important to me, as you know, multiple disciplines are doing vascular access, and it's finding the right person that has availability with the right training and the right competency and the right autonomy to be able to perform what's best for the patient at the time. Dr. Nancy Moreau in 2013 also did consistent with vessel health and preservation for selecting the right device for the right site inserted by the right clinician, right? So right people, that resource at the right time. The clinician performing an insertion must have training, qualification, and competence to perform the procedure in a safe manner. When we get asked or challenged related to advancing scope of practice or inserting a hemodialysis catheter or using ECG for tip clearance for our CVAD catheters, we're always challenged by our medical professionals in regards to competency and training and risk mitigation. Whose fault will it be if you cause harm? So it's very important that we have an underpinning of all of the platform requirements, which include competence, education, and training. And again, I don't mean training one time. Training should be ongoing. And below are the organizations in which support the training and competency requirements for procedures. So SHEA, Vessel Health and Preservation, if you aren't familiar and don't have that book, it's downloadable, open access, it's freely available, it's rich knowledge. INS, ESPN, WACOVA, EPIC, NICE, and AVA. So these organizations are growing, and I could have went outside the boundaries of vascular access and added another dozen organizations. So the framework for training and competency is essential. So let's talk about the state of teams. So I just want you to think about your team for a second. And we definitely can divide our types of teams into three different areas, either comprehensive, reactive, or proactive. So I'm going to start at the bottom of the pyramid, and I'm going to talk about proactive. Okay, so there was a session earlier this week where there was a question asked, when do you advance your scope of practice? And in a proactive team format, you would have done a gap analysis. You would have been able to prove to the hospital, the organization, what your team could do better to impact patient outcome or deliver a critical task earlier or better. And you would have proactively developed a plan, and you would have proactively put a process in place to engage all key stakeholders. And that proactive movement would have allowed you to advance much faster, much easier, because you have the metrics, the design, and the passion behind your vision and mission, and you included all your stakeholders. A reactive type team. A reactive type team can be introduced in a couple different scenarios. Reactive meaning your team is reactive and you're only doing the necessary requirements within your vascular access portfolio. Maybe you haven't advanced to ultrasound IVs because you're too busy doing your other opportunities. And maybe reactive means that the C-suite has now said, hey, we don't have a resource and we need you to pick this up. It wasn't because you proactively looked for it. It wasn't a planned addition to your team, but you're having to react because there's an occurrence happening in the organization. And when it happens during a reactive period, the implementation may not be as smooth, the stakeholders may not be as informed. And then a comprehensive team. A comprehensive team looks at the patient holistically, but also the healthcare organization, identifies all the key stakeholders to see who does the task now, who will they be collaborating with, who would do the task that they're going to do when they're not in the building, who's going to be their champion. And comprehensive teams normally have the autonomy to gain an order for a vascular access device, perform an assessment, and then they are able to select the device and communicate with that stakeholder, the primary ordering physician, on what that device needs to be. And mutually, they agree and they place the device. And that's that team forward approach in that comprehensive model. So just think about what type of team, or maybe where you're going in your team efforts. And then we have different team models that also mix into this here. So we'll start at the tip of the pyramid this time. So a primary vascular access team means that the hospital doesn't have one. It means that every single person with a license in the healthcare organization has the ability to place a peripheral IV catheter or perform basic vascular access, care maintenance, device removal, etc., based on a broad competency maybe provided by the education department. We see this a lot in academic medical centers where we don't have a defined vascular access model because we have a rich environment where residents need training. And then we have the infusion model. The infusion model is licensed providers, so normally nurse-led teams, who have specialized training and education related to infusion medications and provide peripheral and CVAD access, normally peripheral IVs, PICC lines, and midlines. And I think that this is where most vascular access teams, as we call ourselves, live in today's state. If we were all honest with ourselves, this is really what we do. And some are looking to be proactive and move to garnering and inserting more devices. And some people are very happy where they are because they performed a gap analysis and they have coverage for all of those other devices. Because again, when you advance scope of practice and you go from infusion to vascular access, you are taking on responsibility that is high risk if it has low volume. So you want to make sure that you can maintain competency, training, and education in those additional procedures. So the vascular access model. The vascular access model does an assessment maybe upon admission into the emergency room. They may have a 24-hour consult order. They do insertion based on assessment. They collaborate with the healthcare provider. They normally can do all types of vascular access devices within their scope of practice. And in many circumstances, unless you're an NP or PA type team, this is limited to acute non-tunneled catheters at this point in time. But those are the three models of vascular access teams that we do see in the United States and abroad. So a little bit on team reflection here. So a vascular access team is the grouping of healthcare professionals whose primary role is to assess, insert, manage, perform surveillance, analyze their service data, and solve clinical concerns where possible, and remove VATs. So just think about that for a second. Because in many circumstances, when I meet with vascular access teams, and this has a direct impact on the team's ability to improve outcome, is do they only insert? Do they insert and manage? Do they perform surveillance? Because that seems to be quite a gap. Do they analyze their own data? Does the word data scare people? Because many times it does. I get calls all the time. I need somehow to track my data, and I don't know how to read what I'm tracking. Or can you help me simplify it so I can put this into a report so that I can share this with my risk or my quality or my infection team? And those three stakeholders that I just mentioned, risk, quality, and infection, all collect data, are all looking at spreadsheets all the time, and are really your partner in crime here. But I think this is interesting. So when I looked up vascular access teams on Google, this is what came up. this very definition. So just from a point of reflection, now I'll ask you, and I wish you could tell me because I'm looking at my screen, do you have a comprehensive service? Think about that. Do you have a comprehensive service based on your facility type and size? And I'm a firm believer in evidence, and I read a lot of it. And I'm also firmly a believer that you take the evidence in which you read and you scale it to your organization type, style, patient sample, your team efforts, your ability to win in that space. So you don't just take a publication and say, here, we're going to use this, because it may not be applicable to your organization. So when I say a comprehensive service, your service could be very comprehensive for the sample of patients or the type of facility in which you're in. Do you select the device to insert in your patient, or is the device ordered for you? Do you get an order that says patient needs a dual lumen PICC? Or do you device select based on assessment, what medication, how big the vessel is, and what the risk benefit to the patient is? That's, again, a comprehensive approach with the autonomy to make a device choice, because you have respect within the organization and autonomy to be able to do what's right for the patient. This is probably the most difficult one to achieve. Gaining that small hospitals do it. Small hospitals garner the respect and the transparency and the visual really fast. Small hospitals with nephrology teams or nephrology patients end up accomplishing a lot more quicker, because the nephrologists see the time cycle ability for them to win in that space by not having to put catheters in and be able to see patients. So again, do you follow the device after insertion? Remember that in device insertion, and it was greatly said by Nancy Trick a long time ago, and Dr. LeDun has repeated it, and I might have that in reverse, that insertion is only 1% of the device's life. 99% is care and maintenance. And if we don't follow the device, how do we educate that other team member or those other team members that might be interacting 1,000 times more with that device than we did? So if our focus is to put the device in the right way and put the right device in, we should really enhance our focus on who's touching that device when we leave that room. All right, so here's the fun part. Do teams impact patient outcomes? And I'm so honored to have done this research and like done this as my sort of my legacy here. So let's see, you can't be texting me while I'm presenting. So team research, so 2017 to 2018. So the first one I'm going to review here is CAR, right? So I think there was a question yesterday, is the Cochrane review or the Cochrane database a high level of evidence? It absolutely is. It depends on who you are and where you are in academia. But this was a review that was done looking at the impact of vascular access teams. It looked at 30 eligible studies. It takes high level of evidence. It takes randomized control trials, and there was no evidence to support vascular access teams. Johnson, so I included that because that was the staple, right? But I want to go through some of the evidence that does support and what you can use until that randomized control trial may be available. So Johnson here out of Arizona in 2017 published, the benefits of a dedicated vascular access team include reduction in CLABSI, which resulted in decreased expenses and increased efficiency, quality of care, and patient satisfaction. That is huge, right? So that is one piece of evidence in which you could use to talk about cost, efficiency, and reduction. McDermott out of Canada also published in 2017. They attributed our low rates of major complications to nurse-led expert insertion teams, standardized care and maintenance protocols, high insertion volume, novel catheter materials, and continuous improvement initiatives. That means that her team continuously looked at the evidence and implemented strategies with a team approach to reduce harm to patients and reduced overall major complications. So very important research there. Then we continued to move down in 2017. Wallen, did use of a dedicated team for DIVA patients, reduce the lag time from physician order to actionable diagnostics of administrative medications. So this actually allowed them to treat patients safer in overcrowded areas such as the emergency department and added better throughput. So patients on that very first insult to injury, where they get um, that first attempt success in the emergency room, they were able to show significant changes here. Savage in 2019. A dedicated vascular access team contributed to the reduction of central line usage. So now they're doing device selection appropriately when comparing a 16-month period before and after the creation of a vascular access team. It is essentially important that people within your organization, like infection control, risk management, the CFO for finance, know that you and your team are device selecting appropriately, which has financial ramifications because that allows you to build your team stronger. RAZA in 2019, a dedicated vascular access team approach for the care of dialysis access, helps in early identification of complications and improve vascular access outcomes. Vascular access patients with dialysis catheters, whether they are acute or chronic, that is their only lifeline. That is their salvage. Like, that is so important. Not that all CVADs are not important, but those patients own that line. There was a great lecture yesterday about dialysis. It's so important that we understand that we have that patient for a moment, they have that catheter forever. So again, the care and maintenance, and why there's a disparity between how a tunneled catheter versus a non-tunneled catheter is cared for. It's almost like two different conversations in most healthcare organizations. So again, your vascular access team should know what's going on with the dialysis team. All right, so Sarah Krein, uh, data suggested that nurse PICC teams play an intricate role in PICC use at many hospitals, and that the use of such teams may promote practices to prevent complications. And this is really related to the right line for the right patient at the right time. So device selecting, and this was specifically around PICC use in the Michigan area. And then we go into 2020. So Bell and Spencer did a quality review that demonstrates that a dedicated team in a small community hospital can successfully place ultrasound guided IVs and improve vascular access outcomes across patient populations. So this isn't just big teams doing a lot of big things, it's small teams doing great work. So again, introduction into the emergency room. Think about it. If your patients could have a better experience with IV access in the emergency room, wouldn't they be a better patient for you once they get to the floor or to the ICU? Carico did the calculated of savings on the implementation of a vascular access team was 61% compared with PICCs implanted by anesthesia. So again, saving the healthcare organization money, but also probably outcome related when you look at outcomes between the two groups. So 61.81% is pretty big. Martillo, in 2020, a retrospective analysis of data obtained over a span of 24 months after implementation of a vascular access service. They identified progressive decline in CLABSI rates and standardized infection ratios, because remember, we've moved from CLABSI reporting to SIR reporting to level set the playing field. The reduction in CLABSI was attributed to appropriate triage, insertion, and maintenance. So it's not just the device getting inserted appropriately, it's not just the right device going in, but it's the maintenance that is also pulled into that. So maintenance, I wish you could raise your hands and tell me how many of your teams do the maintenance of the device, or you follow every line every day, because that's really where we're going with outcome metrics and management. And then Holder in 2020, a significant decrease in CLABSI rates temporarily related to expansion of the vascular access team occurred in two hospitals, where the hospitals with existing robust vascular access teams demonstrated a moderate decrease in CLABSI rates. Again, that's probably because they're sustained versus new, and the process change, and that initial impact demonstrated. It demonstrated a favorable ROI for vascular access team expansion without impact of hack penalties, because some organizations think that if you add or change something, you may have a spike. In this scenario, introduction of a vascular access team actually risk mitigated and caused a reduction. Okay, so then we have Martillo again, describes the role of novel vascular access in the prevention of catheter-related bloodstream infections. It was attributed to appropriate triage. Okay, that might be a duplicate. Deglano in 2021, so now we're moving into this year, right? Highlighted that a structured vascular access team is necessary to respond adequately to COVID-19 patients. Boy, oh boy, has COVID been changed our world, made us think outside the box and have us do things a little bit differently. They utilize this to effectively maneuver to reduce complications and save waste and save resources during the COVID pandemic. Christoph in 2021, and just as you're looking through these publications, because I'm going through them a little bit fast and you'll have access to this, they're not all in one journal. They're all over the place. This isn't just our journal promoting one thing. It is multiple journals promoting the effectiveness. And it's going to take some of us to do some studies to really show this at a much higher level. But Christoph did a quality improvement initiative on a timely central access in the neonatal intensive care. And just for everybody's awareness, the neonatal area has had vascular access teams for a long time. And there is a lot of evidence that's predicate to 2017 that may not be in this list, because they do have a nice pool of evidence for dedicated teams. They've always done team type models in the NICU type area. So implementation of a unit-based interdisciplinary specialty team led to a 50% reduction in mean PIC wait time. So that means the baby, that child, your child, didn't wait to have vascular access. They were able to reduce the wait time by 50%. So think about your average wait time for your patient to get the right access in. How long is it? Honestly, how long does it take from order to insertion? And then Holt in 2021. The vascular access specialist team model is evidence-based, follows best practice guidelines, is physical sound, and optimizes nurses' practice and quality patient care. Like, that's huge. That's exactly why many, many years ago, we transitioned to the vascular access specialist, because of all those things. We implement best practices. We optimize performance. We seek opportunity to reduce risk, and we improve patient quality of care. And then this, I'm super excited to share, and I'll share this over the next couple of slides, is my doctoral research. So it calls a comparative examination of CLABSI, vascular access teams, and hospital types, because it's not just it's not just if you have a team or not, right? It's not just what your team does or not. It's not what the reported outcomes are, but it also, where a lot of the gray area is, what about teams in academic centers? What about teams in teaching versus non-teaching hospitals? There was some questions this week about how do you implement such a strategy if residents need to continue to train, right? So that becomes one of those hurdles that we have to hurdle. But I always say to vascular access teams seeking to advance scope of practice that even in teaching or academic hospitals, you're not asking to take over everything in the organization, at least not right away. Be careful what you ask for, because it comes fast, right? And you become the expert. What you're asking for is to place the right device in the patient that's appropriate when you receive an order for a consult or a vascular access device to be placed. And through assessment, you identify that device to be different than what the physician asked for in the first place. So many of my resident-based hospitals call me and say, how am I going to keep my residents get their 5 sticks? Those residents are still going to insert their 5 lines. You're going to insert a central line when a central line is needed, acute central line, if a PIC is ordered and the patient's appending a code. Or you're going to place a PIV when a PIC is ordered and the medication profile, the anatomy, the assessment, the time of therapy, or the type of medication characteristic doesn't warrant the PIC. So that's what you're doing. And that's sort of the language that you need to take, or else you'll get a lot of roadblocks. So you're not taking things away from anybody in any type of facility. And you should not assume that a resource is available in any type of facility if you don't do that procedure yourself. And I'm going to try to share a little bit of that with you. So my research spanned over 6 years. People kept saying, Amy, are you ever going to be a doctor? So it's finally here, thank goodness. And I encourage any of you to take your passion and run with it, because you can definitely achieve it. So this is a causal comparative examination of CLABSI, and I use the NHS and reporting database. As you heard from the last speaker, they have a comprehensive reporting mechanism that all hospitals in the United States report all. And it's an open access database where the numbers are freely available and open to the public. And this looked at all 3,700 hospitals in the United States that were currently reporting. And what was interesting, I didn't look at all 37. I did pull all 3,700 hospitals, but I did a sample size based on a power analysis. And I looked at hospital type, whether they were teaching or not teaching, and vascular access team either present or absent. And this was interesting in itself and will lead to future research, because the vascular access team present or absent was through a phone inquiry to the hospital infection prevention team, in which many did not know what a vascular access team was. So we definitely have work to do there. And there's definitely going to be some additional opportunities through AVA and others to increase the awareness to that. So the first research question for this was address the mean difference between reported CLABSI rates based on hospital type, teaching and non-teaching, and hospitals with a vascular access team. So it basically looked at what was the CLABSI rate for teaching and non-teaching hospitals in the sample size of 128 hospitals, and did they have a vascular access team or not. A 2A ANOVA variance was used, and this is very research heavy. So if you want to talk about this after, I'm happy to. I'm excited. I have the book right behind me. And I'll walk you through some of the structure if you're interested. The results of the ANOVA was significant. So that means significant, as John described yesterday, meant that there was a significant impact by this one variable within the healthcare setting, which was either the hospital being a teaching hospital or not teaching hospital, or the team being present or absent. The p-value was clinically significant at p of 0.001, and indicated there were significant differences in reported CLABSI among the level of hospital type, meaning that teaching hospitals reported a higher rate of CLABSI than non-teaching hospitals. Now, you have to remember that SIR has been introduced to NHSN to level set the differences between CLABSI reporting in whole numbers and it being ratioed, a normalization ratio to the hospital type and size. I did a calculation of SIR, and the numbers are almost identical. So it was very interesting to see how NHSN duplicated that and reproduced that as SIR. The main effect, hospital type, was significant, indicating significant differences in reported CLABSI based on the hospital type alone. The main effect of team present or absent was also significant, indicating there were significant differences in reported CLABSIs when there was a team present or there was no team at all available to the patients. Research question number 2. This addresses significant mean difference in reported CLABSI rates based on the vascular access present or absent only. A 2A ANOVA was used for this and paired t-tests to answer these questions. The results showed that there was a significant mean difference between a team being present or absent. And there was significantly larger number when the team was present, or when the team was absent than when was present. So basically, hospitals that did not have a team had a higher reported CLABSI rate. And that's really what we were looking to prove in the research. Does a vascular access team impact the reported metrics of patients, which would be CLABSI? And what are the variables that those teams can or can't do to make that and to demonstrate that impact? So this demonstrated that regardless of hospital type, with a vascular access team present, they did have a significant difference in reported CLABSI. So when you look at the research in general, the academic centers that had a vascular access team present had an impact, but it was lower than the impact when there was no team present at all in a non-academic. And me as the author attribute that to the resources available in the hospital in an academic medical center. And there's definitely 2 or 3 more research projects that are going to come out of this research. But really garnering the fact that um, we as vascular access specialists have the opportunity within our healthcare systems to impact is very important to understand and to know. And there needs to be more research for this. I mean, that's another 6 years of diving into research and doing this structured analysis still tells us that there's a lot more work to be done in this space. Going back to what Peter Card said in 2017. So really, defined teams do positively impact variables associated with vascular access. So a defined team, if you think about if we can garner the device insertion earlier, if we can insert based on assessment, if we can not place a device if it's not clinically warranted. And what we haven't talked about really is device removal, because not just inserting the right device, but owning that device through the care continuum and removing that device when no longer clinically indicated. Whose responsibility is that? Is that your responsibility as the inserter? Do you get that impact of the negative outcome? Does that get reported to you? Does your team make a change based on what you found out? Because that's the circle of vascular access. That's the continuum of care. Teams do play a key role in device selection, dwell, and removal. They don't just play a key role in device selection, but they should play a key role in device utilization, right? You should know how many devices are in that house every day. How many devices could come out, right? Do that daily rounding or be part of that core team. This takes more people, more FTEs, more teams. And I know there's some of you that are listening to this and you're a team of one, and I applaud everything that you do. But you need more resources to really impact your healthcare organization in the way that you need to. And in the future, I don't want to talk too much about it, but we will be establishing the number of vascular access specialists required based on hospital size in some future work that will be coming, and you will see it as AVA members. Quality improvement by all teams should be ongoing, transparent, and shared. That doesn't mean you collect it, you save it, you analyze it once a year, and it's good to go. That means every month, your key stakeholders, quality, infection, CFO, they're expecting something from you. You review it with them, and they appreciate you. I mean, you deserve a lot of respect for everything that you do within the healthcare system. In addition, if there's a bloodstream infection, or if this does become reportable for all devices, you need to be part of the throughput team or the workflow so that you're not seen as part of the problem, that you're seen as part of the solution, and share what you're doing or implementing. If it's sterile IVs, or if it's using a probe cover, whatever you're doing, that and when that change was made, so that quality can look at it and see you as a benefit. Both teaching and non-teaching healthcare organizations should employ vascular access teams as a standard of care. This reduces CLABSI, it improves patient outcome. Every single patient, regardless of hospital type, because patients don't care what type of hospital they're in, everybody needs an IV. And if the first one isn't great, then we've just impacted the entire life cycle of that patient's admission. So very, very important that we put a lot more emphasis and importance on IV therapy. More research is needed. Team characteristics, what constitutes a team, what that team does, how much more work or support a team definitely needs to be outlined. I did submit this publication to AGIC, and that was one of their questions was, what is the difference between, what's the difference between all these teams? what do all these teams do a little bit different? Are they using a different product? Are they using a different practice? Do they have different policies to support what they do? Or have we standardized the vascular access service model enough that IPs can say, we have a vascular access team, they're comprehensive in their approach, they use the right device, they audit, they survey, they remove, and I have full appreciation for the vascular access model. I don't think that we're there yet. I don't. But we're getting there, and we're getting there together, and we're getting there certainly with AVA's help. So this is just a statement from me in closing of this session. Device selection and insertion is only a small part of the patient experience. Vascular access services need to be holistic with a planned evidence-based continuum of care, which minimizes devices-related complications and maximizes the value of each of you, the dedicated vascular access model within your healthcare organizations. I'm trying to move my slide, but it's not going. Could you move me? Thank you. I will now turn it over to building a case for the need of a vascular access team in a large academic medical center to Jonathan. Thank you.
Hey everyone, my name is Jonathan D'Alessio. Thank you so much for joining us today. Thank you, Amy, for that wonderful presentation. It's almost like these two presentations were meant to be together. What we're going to go over is building a case for the need of a vascular access team in a large academic medical center. I'll be presenting with Marissa McMean and Kelly Zabriskie, who both work in infection control in our institution. They were, it was a big part of working with them and infection control and amongst other departments to be able to get to where we are today. So I'm really excited because, when we first started this journey, our vascular access team, which we did call the PIC team, which was so common, and it was so interesting that Amy went over that. We had 1.5 employees, and I'm really excited to share with you guys how far we've come and what we've accomplished. We have no financial disclosures. So again, I'm Jonathan D'Alessio. I've been working in the field of vascular access now for 8 years. I kind of had a weird journey to where I've gotten to now. I actually started out in interventional radiology at a small community hospital, and then that's where they trained me how to place PICs and midlines, but mostly just PICs at that point. My first AVA conference was 3 years ago. And since then, I have even gotten more involved in vascular access, and it was so exciting for me to be there. And I'm sure I was in a position like many of you are, where you're getting all this information, you're talking to other people, and you want to bring all that information back to your hospital so you can expand your team and do what's best for the patients. And then what inspired me too is to become board certified. So I became board certified a little over 2 years ago after attending my first conference. And since then, I've become the coordinator of patient care services for the vascular access team at Thomas Jefferson University Hospital. I've been there for 6 years. I've worked with numerous groups throughout the enterprise now, and I'm a member of the CLAPSI working group, which was a big part of helping grow our team and realizing where we could fit and how we can make a difference in reducing CLAPSI and also increasing patient outcomes. I'm going to send it to Marissa now.
Hi, everyone. I don't know if I'm on the screen. Yep, I think I am now. So, hi, I just thought I would introduce myself really quick. I'm Marissa McMean, and I have been an infection preventionist for over 10 years. I currently work at Lantana Consulting Group, where I'm a contractor with the CDC's NHSN, the Division of Protocol and Validation team. And I previously worked at Jefferson for over about 10 years, and that's where I worked with Jonathan and Kelly. And I was the CLAPSI infection prevention lead there. And then I'll let Kelly give her a little background about her.
Hi, everybody. My name is Kelly Zabriskie. Currently, I'm the Enterprise Vice President for Infection Control for the Jefferson Health, which is located in Philadelphia. But at the time of initiating this team and moving forward with the efforts, I worked as the Director of Infection Control at Thomas Jefferson University Hospital with Jonathan and Marissa. Currently, I am the co-lead of a CLABSI action group for Jefferson Health, where we are standardizing best practice initiatives across the enterprise, where we've gathered infection preventionists, nursing, physicians, and we've gathered together to come up with best practices and processes to help reduce our CLABSIs regarding care and maintenance of lines, and trying to standardize infection control timeouts and so forth. And Jonathan is a big part of that team, and we rely heavily on him with this group. I've worked in infection prevention for the past 17 years. And as I said, I worked for 5 years at Thomas Jefferson University Hospital as the director. One thing I was an honor for myself is I recently received a doctorate of science, an honorary doctorate of science for leading the COVID initiatives for Jefferson Health and Thomas Jefferson University, which of course also impacted COVID also, obviously, as we've mentioned before, impacted the CLABSI rates tremendously. So I'm going to talk a little bit about our learning objectives. First, we want to recognize key factors in justifying the need to have a vascular access team. We want to understand how vascular access impacts patient hospital admissions and satisfaction, as well as know the financial impacts of CLABSI and how vascular access teams can be vital in reaching targeted goals. So I wanted to give you a little bit of background about our institution. Thomas Jefferson University Hospital, like I said, is located in Philadelphia, Pennsylvania. We're a large academic medical center. We have 926 licensed beds. We are in 2 different locations in Philadelphia. We have a Center City division, as well as another hospital about 5 miles away that it's Methodist Hospital. In fiscal year 20, we saw over 39,000 inpatient visits. And in the outpatient setting for fiscal year 20, we had over 1.25 million visitors. We are part of a larger Jefferson Health system, which spans parts of southern New Jersey, as well as some of the other counties locally around Philadelphia. So I wanted to talk a little bit now about the journey that we undertook to getting a vascular access team. So as you know, central line associated bloodstream infections are one of the most common types of hospital associated infections. We know that patients that acquire a CLABSI during their inpatient stay have a longer length of stay. It raises mortality by 12 to 25%, and it has higher hospital costs compared to those who do not. It's estimated that someone with a CLABSI infection has an estimated increase in cost of $48,000. So it definitely impacts the patient and the hospital in so many ways. So we know that these are most preventable when evidence-based practices are followed consistently. In 2018, we noticed that the CLABSI standard infection ratio, which was mentioned previously in the last presentation, had begun trending above the benchmark. So here you can see this is a graph about our annual CLABSI standard infection ratio, which the standard infection ratio, as was mentioned, takes the observed infections over what NHSN uses to say what your predicted number of infections you should have. And that's this number here that's given. So you can see our numbers were low, and in 2017, NHSN changed the baseline, which started including the med-surg units. And our number did increase. And what we saw in 2018 is that, again, our number started trending upward. And we realized that we needed to start looking more intently at our practices and trying to identify what we could do differently. So we needed to come up with a game plan, grab our teamwork, come up with some plans. So we started thinking about what can we do. We did, as Jonathan mentioned, have a pick team. It was a small team. They were stretched very thin. They worked very hard, and they were very successful, but we needed more. So we collaborated with the infection preventionists, the CLABSI team, of course, the PIC team, the vascular access specialists, radiology, pharmacy, and physicians to come up with what are our goals? What do we need to do? We realized that we needed to expand this team, but we needed some information. So we started researching what other successful teams did to try to identify best practices, best processes, and what we thought we could manage. So we had to identify, though, the deficits, the challenges. We need to look at clinical outcomes and costs of having a vascular access team. As you know, there's a lot of factors that go into presenting a case and what we needed to do. So we needed to gather everybody together to come up with a plan. We assigned the most knowledgeable clinicians to be part of that game plan, and we needed to look at all different parts. We realized this team could have impact with VAD selection, skillful insertion techniques, managing infusion methods, vascular access care, and evaluating clinical outcomes. All these things we realized would help us with our central line bloodstream infections, as well as do the best thing for our patients. And that was part of our talk. What was the best thing that we could do? So now I'm going to turn it over to Marissa to talk about the creation of the team.
Thank you, Kelly, for that. When doing our research for other ways to combat our CLABSIs, we saw that studies show that when there's a dedicated team inserting and maintaining these central lines, that CLABSI rates did indeed decrease. We really wanted to decrease those CLABSI infection rates, as you saw from the previous graph, because they were pretty high from what we were used to. And we also wanted to decrease our central line utilization, which was pretty high at the time. And we realized that using the expertise of specially trained and certified vascular access nurses in not only the insertion of central lines, but also the care and management of the central lines as an additional or first line of defense in reducing our CLABSI rate. In order to create a robust team, we knew that there was a clear need to expand our PICC team to a 24/7 vascular access team that would insert not only PICCs, but midlines and ultrasound-guided peripheral IVs. We wanted to expand their job duties to include daily rounding on patients with central lines in relation to the care and maintenance of their line. So that would include asking the patient, did you receive your CHD bathing? Because we required CHD bathing on all patients with central line, daily CHD bathing, or making sure that it was documented in the medical record, or checking the dressing. Was it clean, dry, and intact? And if not, did it need to be changed? Looking to see if your alcohol caps were on all the ports. That would be part of their job duty. And also, we wanted to use their expertise to provide the education and competency to staff using the line on a daily basis, because vascular access nurses really are the experts, and the others are the so-called generalists that know everything, and we wanted to use their expertise in educating. So we know that the current PICC team that we had is extremely great at their job. I mean, Jonathan, for being the one full-time person that we had, he was great. But we knew he was really stretched thin. And when we constantly would talk with him, we had to figure out a way to help him out. So we knew that we needed to add additional vascular access nursing staff to successfully have this program be effective. And I know I'm speaking to vascular access nurses, so you know what they are, but we wanted staff that were registered nurses who are trained in vascular access and have the appropriate specialty certifications and are considered the experts in their field. So let's get back to where we started. And we started this journey in 2018. And as previously mentioned, we were a small PICC team. That's what we called it. And that was in our Center City location. And it consisted of one full-time employee, and that was Jonathan, and another part-time employee. And as you can imagine from the slide how large our facility was, that clearly wasn't enough staff to cover what we wanted to do. So when we started our business case for administration, because we had to create a business case to, plea for this team, we noticed in our data for calendar year 18 that an average of 27 lines a month were unable to be completed the day that they were ordered. So as you know, they would have to be completed for the next day. And then patients are waiting for another day to get their line. And that some patients could be discharged after they were just waiting for that line to be inserted. And an additional thing to note was that our PIC team operated at that time Monday through Friday from 7:30 a.m. to 4 p.m. I mean, 4 p.m. really isn't that late, especially if teams are rounding and they're rounding later in the afternoon and they order the PIC. And especially because if it gets ordered on a Saturday morning, that patient's going to have to wait till Monday after the weekend to have their line inserted. So we all know that a delay in vascular access placement can lead to a decrease in patient satisfaction and an increased length of stay. And that's very important, especially in today's the world with pandemic. If somebody can be discharged if they were just waiting for that PIC line, many hospitals today are at their brim. So it's very important that we get these patients out as soon as they can. And especially because there's a huge potential loss of revenue. We did some looking into it and saw some average daily hospital costs from AHA, and that we had, over $800,000 of potential loss of revenue with patients that were staying longer than they needed. And here's a graph that we created for the 2018 calendar year to show to administration the data. So you can see here, like in October, that month, they had 54 leftover lines for that next day, which is huge. That's a lot of potential patient, decrease in satisfaction and loss of revenue. And to talk about the rest of our journey and where we are going and where we went, I'm going to turn it over to Jonathan.
Thanks, Marissa. So inappropriate device selection. So let's talk about the device selection in general and how it works in our facility. What happens is we get an order for the specific line that team wants for that patient. So they'll order a double lumen PIC, they'll order a midline, whatever it may be. So we, as the experts, then have to decide what is the best line for the patient. So what I'll kind of get into what we're working on now a little bit later, but we're trying to change that practice because right now we already choose what the appropriate device is. We just have to make extra phone calls and, it kind of slows the process down. So, but what we see, and most of us see this every day in our practice, is that patients often complain about being stuck so many times. And, that's really going to decrease satisfaction scores, but also it's going to increase other complications, such as infection. You could still get a bloodstream infection from a peripheral IV. And we're seeing patients, by the time we get to them, stuck 7, 8 times or more. So, when I first started at Thomas Jefferson in 2016, midlines were being placed to kind of solve this problem. And I think we can all appreciate that. We all go through the same thing. There was no other resources for the nursing staff and for the physicians. There was not many people trained in ultrasound guided peripherals. We were the only 2 people in the hospital, me and another part-time nurse, who could place midlines for vascular access. And we didn't have the resources to become, an IV team. And as we all know what midlines are, as per our hospital policy, they can be left in for up to 29 days. And as we all know, the new 2021 INS standards, they may dwell for as long as clinically indicated. So that is something that we are going to go back and we have to change our policies, just like Amy was talking about earlier. So then what we brought in recently, as of April, is the use of an extended dwell peripheral IV. It would be more appropriate and cost efficient. And we're going to kind of go over the cost savings and the benefits of using an extended dwell rather than a midline in a lot of these patients who just need general IV access for whatever they need. So one thing that we had to look at when creating our team is where can we, cut costs to justify having these positions. Unfortunately, hospitals need to, look at that. They need to look at the financial implications of hiring extra staff. What are the savings? And it's something that I've been learning throughout my career. When I was, new in vascular access, and I'm just like, oh, I don't understand why people, we're working so hard. We need these extra positions. We need help. We need to get these patients the right access, and they know they're suffering, et cetera. But we had to break it down into, finances and where we can save save money. So where we cut costs. So midline catheter, we use a max barrier tray. It's $120. We use a 4 French 20 centimeter single lumen catheter, which is trimmed to the appropriate length for that patient. So then you want to look at the cost of an extended dwell, peripheral IV. For that, the custom kit was $58, and our institution decided to just go with one 20 gauge, 2¼ inch extended dwell peripheral IV. And we started looking at extended dwell peripherals. It probably was over 2 years ago when we started that process. So it wasn't until recently that we actually started using this. So we don't have any new data on the replacement of extended dwells versus midlines, but that's something that we're still going to be working on and still going to be following to see those cost savings and to see what benefits that we're providing for these patients. Midlines do also have their complications. We have to look out for DVTs. I think that's something really important that we've seen an increase of them in our institution because prior to getting an extended dwell IV in the institution, we were replacing so many midlines, and they could have been just for one or 2 days by the time that they consult us. So an extended dwell would be a great option for them. And you can see $120 versus $58 is a huge deal. That can be a lot of cost savings, especially at an institution at our size. And, we are the only ones who do place IV access in these difficult patients. The nurses do place lines on the floor, but, as patients have multiple comorbidities now and they're becoming sicker, especially post-pandemic, we have seen such an increase in our vascular access needs and the demand on our team to provide access, even if it's just for a very short time. So what we need to do is calculate the cost savings. So when we first started this whole project back in 2018 with Kelly and Marissa, that's when we really started tracking data. We didn't really track data before then, unfortunately. So what we did is we looked at our midlines inserted in 2018 that were placed for less than 5 days. And as we all know, per INS guidelines, a midline isn't really meant for the use of less than 5 days. And we realized at that time, 405 midlines for that calendar year of 2018, were in for less than 5 days. So now, we can look at that number and then we can calculate that into some cost savings. So the total cost for a midline placement for that many patients would be $48,600. So right there, we're spending that much money on, a line that isn't necessarily indicated, but the only type of line that was offered, at least by our team. No physicians really knew how to place ultrasound guided peripherals again, so we were that only access point. So, the midlines are great because it also helped reduce central lines at the time, but that there wasn't even much of a cost savings when you look at central line infections prior to midlines. I think there's definitely a benefit, but we got to look at more of a cost savings. So, now, if we replace those 405 midlines with an extended dwell, which is what we want to do in our business plan to just show a little bit of a cost savings, that total cost for an extended dwell would be $23,490 roughly. So that's a potential cost of $25,000, which is pretty significant. In the grand scheme of things, just a small piece of many other pieces of the pie. So then I just want to kind of explain our current team. So in the beginning of 2020, so we're kind of halfway through this whole process where we started in 2018. 2020 came along. We were able to hire 1.5 FTEs just based off of the data that we were starting to show an increased number of placements, the need that we need to be able to provide more vascular access for our patients. So you can see at the time, we're still called PIC team. And I think that's something that I've been working on, is trying to change that culture of that we're a vascular access team, because prior to getting an extended dwell put in place, we were just placing PICs and midlines when we get to them for IV access. Now there are those patients who are going to be discharged with a midline for a short-term course, but generally we were using them for IV access for those difficult patients. So now our team consists of 3 FTEs, so that's a pretty big deal. We just doubled the size of our team, which still not big enough, but it's still better than what we had, that's for sure. So now we can get to some of these patients sooner. We can hopefully prevent those patients from being stuck multiple times. We can hopefully now prevent those patients from, extended hospitalizations and other complications that come with that. So now our team also operates now Monday through Friday, 7 to 5:30. So we extended the day for 2 hours. Doesn't sound like a lot, but when you multiply that by 5, I mean, that's another 10 hours that we're able to provide vascular access for our patients. So that allows us to get to those patients that need to be discharged, that need TPN, that need chemotherapy. Those are our prioritize. We prioritize those patients, and it allows us to get to those other patients who need IV access, who are getting stuck 10 times, who need to have a CT scan, for whatever reasons. And we all know how that works. You have to have a blood return. You have to have a good secure line. You can't go to CT scan with a 24 gauge IV in the thumb. So for calendar year of 20, we found an average of 11 lines a month that were still unable to be completed the day that they are ordered, which we were able, for the most part, we were able to do. So 11 is much better than the 24, 25 that we couldn't get to in 2018. So we definitely see an improvement with just those 1.5 FTEs, but there's still a gap. There's still 11 a month, which doesn't sound like a lot, but that can be a huge cost savings. So since increasing our FTEs, we've increased our turnaround. But the potential loss of revenue is still $344,000. So that's really where we can, show our CFOs, we can show everyone that this is where we can really save money. And then that's not even looking at complications of, multiple IV sticks, amongst other things as well, collapses, etc. So here's another graph. I know Marissa showed you the one from 2018. So this is the one from 2020. So it's a couple years later. You can see in April of 2020, that's when our numbers drastically dropped down, but that's because that was the beginning of the pandemic. So I'm sure we can all relate to that. And then since then, however, we quickly went up. Our volumes were higher even pre-COVID, and they still continue to grow. I obviously don't have data for 2021 yet, but I can tell you that the insertions are way up, and these insertions include PICs and midlines. So I just want to make sure that's clear. But you can see leftover for the day, there's months where it's still pretty high. July and August of 20, we had 20 to 24 lines left over. And that's pretty significant. Even though the average over the year is 11, we still have to look at those months. I mean, that's large. And then you have to look at patient throughput as well. We're at a time where we need beds for patients who have COVID, and patients who don't have COVID. We do not want to delay a discharge just because we weren't able to get to a PIC in time. So it's time for a new game plan. The number of insertions, just like I was talking about, have increased. And I know I keep talking about midlines, and the reason is because, this is where we can save money. A lot of our PICs that we place are clinically indicated for what they're going through, for what their disease process is. The midlines that we use they were really used for access, and that's all at the time that we could use. So that's why I keep honing in on midlines and how we can save money there, because we are the vascular access team, and we do provide access. We don't have an IV team. I know I already kind of mentioned that. So our total insertions have went up drastically. So now, instead of being 405 lines for less than 5 days, we're at 679. Same percentage. Obviously you can see our volumes have increased now 2 years later. The number of lines placed for more than 5 days is 983 at 59%. So that's pretty good. At least, there's not an improvement, but at least we're kind of staying the same there. So, but again, with that being said, we're trying to decrease that less than 5 number. But still at this time in 2020, we did not offer an extended dwell IV. So we had 274 more insertions for less than 5 days, and that is a potential cost savings of another $42,000. And obviously that number is going to go up. So again, remember, we don't have extended dwell IVs yet, and we're just using midlines for IV access. So I think this is a really interesting slide. So, we were like, what are we going to do? What are we going to do next? So this graph kind of superimposes the numbers from 2018 versus 2020. And you can see the total number of insertions is gone up overall. And the numbers left over for the day, again, I know I kind of already talked about this. It is going down, but I think there's still room for improvement. So these are PICC team line insertions, again, just in another graph to kind of show you how things are increasing with total insertions, and then also in decreasing in number left over for the day. So I think, this is total. So 329 lines in 2018 versus 133. So that's pretty good. So far, I think, again, we can improve upon that. So our future plans and goals, which I think is really exciting, because since this presentation we put this together, there's been some changes. So I'll explain those to you in a minute. But so the future team, so what our plan was or is, and what's kind of been approved at this point, is to have an addition of a lead nurse. Which is where I come in. I'm the administrative charge, or the coordinator of patient care services now, which we've just recently changed the title of in our facility. So for the vascular access team. And like I mentioned earlier, that's something that we're trying to rebrand our team as vascular access, because we do more than place PICCs. We place PICCs, we place midlines, we place extended dwell peripheral IVs, we access ports, and most of all, we do a lot of education, and we're continuing to do more education throughout our institution on vascular access, appropriate line placement, not just appropriate line placement for our team, but appropriate line placement for the residents. When is it appropriate to place a central line versus no central line? Femoral line versus IJ line, subclavian, etc. That type of education is lacking, and that's where this a position for a lead nurse need to come in to manage staff, patient flow, but also to do education not only to nursing staff but also to the residents and physicians attendings throughout the hospital. And what we created, Marissa, Kelly, and I, through our SOAR group and our facilities. So this was a group that was put together just for Thomas Jefferson University Hospital in Center City to help combat CLABSI. And one of the things that we came up with was these CLABSI champions. Ideally, our team wanted to, we wanted to provide audits throughout the hospital, central line audits, checking dressings, making sure curious caps are placed in the line, making sure tubing is changed, all of the items in our CLABSI bundle. But when we looked at how many central lines there are in any given day at our institution, there's 200 central lines. It's impossible. I don't want to say impossible, but you would need a lot of FTEs to do daily rounding lines for the vascular access team. So what we came up with was CLAPSI champions. So there's 2 nurses from each unit who we educate on our CLAPSI bundle, on the INS guidelines around CLAPSI and central line infection prevention. We did a course with them, and they continue to come to our CLAPSI committee every month just to see what's going on in the hospital, go over CLAPSIs, ask any questions, report out, what they've seen on their unit. All of this information is then put into the audits that they do is done in a red cap survey, and that information is pushed out to nurse managers of that unit every month. So we've seen an increase in a lot of things, but we also saw where there's gaps in where we could do better in helping prevent CLAPSI. And that lead nurse for our team, amongst managing the daily workflow, would also help keep education up to date for those annual education for CLAPSI champions, at least annual, or if anything else new comes out, to update them, but also keep the enterprise, our health system. So we have a lot of hospitals throughout the Philadelphia area, and we need to all be aligned on the same process and procedure and guidelines. So it would be my job to help facilitate that and make sure everyone is doing what's best. And as we know, it's not easy to do, and it takes time. So then what we wanted to do was have 2 teams of 2 people in the Center City Hospital. So, one team, would have 2 nurses, and they would go out, place picks, place midlines, etc. The other team can, place extended dwell peripheral IVs. Or the idea is that maybe they can do audits online, even if it's just, going to a unit weekly, doing random audits, get that non-biased view, making sure everyone's following proper guidelines for CLAPSI prevention. And then also, I know Kelly kind of mentioned this earlier, is the second person as the circulator or observer. As you know, we need timeout. You need 2 people. We also really need someone there in the room with you. We've all been there. We still do. We have to go place a pick, and you're so short-staffed, and you're the only one in there, and the nurses can't help it. They can't be in the room with you. We've all been in a position where we drop something, and we need to we drop something on the floor. We need to drop a new item on our sterile field. Well, now that you have to deglove, you have to, there's a risk for contamination. Those are all things that can help also justify having a larger team. And then also we implemented observing perform a checklist, make sure that everyone is doing the proper thing. So that's where we want to be, and also have that another team down at Methodist, which only consists of 1 person. So we need a team of 2 people there every day. 1 person is not enough 5 days a week for 8 hours. And as we continue to grow, and as we all have experienced an influx of patients in our facilities, we saw a need to increase that to 2.5 FTEs to provide 10 hours a day of patient care when it comes to vascular access. So we have and just a little bit of background on our Methodist hospital, which is why they're also so busy, is we have a migraine headache, which requires them to have every patient gets a double lumen pick. Well, they have like 7 admissions a day, especially towards the beginning. So we need to be able to provide that patient with the proper line when they get there in a timely manner, so that way we can start therapy and they can get discharged sooner. So, and then just to kind of explain to you where we are is, after, I want to say a month or so ago, we got approval for 5 additional FTEs on our team, which would allow us to reach that goal, our future, our plans that we wanted to initially, that I just kind of went through with you. So, which is really exciting. It's taken a long time to get there. We obviously still have to go through a lot of training to get everyone up to speed, before we can actually implement what we want to. But the fact that we have an additional 5 FTE, so when I started in 2018 or 2016, or oh gosh, maybe since 2015 now, 6 years ago at Jefferson, it was just 1.5 FTEs. Now we're going to have 8 or 9 FTEs on our team, which is huge. Never thought that would happen. We've went through so many different iterations of the business plan that we put together over time. And we've been to several meetings, and there was times where the plug almost got pulled. Several times. I mean, even up to the last minute, the plug almost was pulled. But we just kept on fighting for it, and we got what we needed. So which is really exciting. So just be patient. I know many of you are probably in a very similar situation. But the goal is to provide safer vascular access for all patients by decreasing length of stay, decreasing CLABSI infections, which decreasing unnecessary central lines, and in turn, increasing patient satisfaction scores. I know we keep talking money, but we can't forget that these are patients, and we want to do what's best for them as well. And this will help us attain our goal of moving forward as a high reliable organization. It'll support us in reaching our CLABSI goals for value-based purchasing and reducing hack penalty, which is going to help increase our national ranking, making us not look better, but be better. We are better. So again, like I kind of just mentioned, the game plans are continually evolving. So, our plan that we started with is very different from what we ended with. But we still ended up with the same outcome. And you have to be ready to change and update them as the play continues. And I just want to make sure, you have to be patient. You have to be persistent. And, that there's so much evidence out there that you've already heard throughout this presentation to support having a greater team, having a larger team. So use that evidence, use that work that our colleagues have been working so hard on. So yeah, thank you so much for listening. I really appreciate it.
Thank you all for that amazing presentation. Now, this ends the CE portion of the session. Be sure to write down the CE code for normal. And we have a ton of questions to get to. So let's bring all the presenters back and let's start chatting. So what is the VAT? And I'm going to throw this out to the group. Whoever wants to answer it, just jump in. What is the VAT team responsibility for providing education? Okay, I'm going to pick on one of you now.
You want me to start?
Amy.
So internal to the team's education is one, as Jonathan said very well, keeping them updated and current on the guidelines and standards, because although they evolve and they get published, not everybody has access to them and may be aware of them and into the intricacies of things that they're doing within the organization. I think where the gap here, Judy, is who's responsible for training the primary stakeholders, which is every nurse that touches that device. So, I think at minimum, the vascular access team should be involved in whether it's orientation, onboarding, or vascular specific training requirements within the organization. I think we have some opportunity there, and I think that the vascular access team does a lot of just-in-time training, and that should represent how much more training might be needed. But I'd ask Jonathan as well what his thoughts are.
Yeah, I mean, I agree completely. And that's something that at our institution we were lacking, is that new nursing orientation. There was a very small education piece that we weren't really involved in when it came to vascular access and central line care and maintenance with any sort of central line, whether it be a port, PICC, IJ, femoral, dialysis catheter. So it wasn't until recently that we kind of have a spot at the table now to help educate those new nurses on vascular access. So that's exciting, and that's been evolving even just as like 2 weeks ago.
Fantastic.
Thank you, guys. Okay, Jonathan, this one's out to you and your team. Have you
Okay.
considered adding non-nurses, so respiratory therapists, LPNs, others to your team?
Yeah, so this is actually a good question. I know I didn't really touch upon it, but we have a medical assistant on our team who acts as that second person. And I don't know what other institutions do, but I know it's not it doesn't seem like to be a common practice, but it works really well. They help set up sterile fields. That's within their scope. They assist in dropping any supplies that we need during the procedure. So I think it's something to look into if you're growing your team. We have one now. We're still in the process of filling the 5 positions that we got. We're even debating on maybe splitting one of those into having multiple MAs, which would allow us to have 2-person teams. It allows for more flexibility as well.
Bravo. I love that. I want to see you publish soon too. That would be great on this multidisciplinary team that you're running
Yeah.
or working on running. I love it. So, Amy, when you called hospitals about the existing vascular access teams, did you encounter hospitals who had existing VATs yet mentioned decreasing their scope of practice instead of expanding?
So in the research, it was actually a qualifying question. So not in the research specifically when I asked about their vascular access team, but I can tell you personally, I get a monthly call from a team that's either being disbanded, and it hasn't happened so much during COVID, but prior to COVID, and asking and seeking support to help them articulate their value. So that is still happening, every day. I just think that it's being overshadowed by other busyness, in the hospital right now.
I hear that too. Agreed. Okay, going out to the group, but Amy, I'm going to push this one at you initially. Getting some legislation in front of the government about requirements for vascular access teams is critical. Congress generating funding through CMS. CMS doesn't understand the impact of all the importance of a vascular access team. We must change this and use the government to help drive it at institutional levels across the US. How can we help achieve it?
Yeah, so this is my unfortunate statement. My unfortunate statement is that penalty causes procedure change and process change. And when we get a holistic definition and requirement for reporting of BSI, regardless of the vascular access device, these teams will be invigorated and required and sought out. And CMS will recognize it, and other organizations will then too. In 1999, they were disbanded, and unfortunately, after they were disbanded, there wasn't a lot of research showing the impact of the disbanding of the vascular access teams, which they were infusion teams at the time. We now have enough evidence to support, the impact of vascular access teams and what they do for patient outcome. So I don't think there's a chance we'll get disbanded again. The risk here is that when that does come, right, when that holistic definition comes with a pay for performance penalty tied to it, we will be very busy, and we will need to be very good at what we do to risk mitigate with every patient that requires an IV. So there's work to be done there, Judy, but I think that's the first step. And I think the second step is the research that we're continuing to do through AVA with identifying the requirements for a hospital by size and how many vascular access specialists are required based on that type of organization.
Okay. Other team, Jonathan and company. Would you like to comment on that?
I'm not too familiar with that, but I agree that I think it's when we were looking at building our team, again, like I kind of went over, it's so difficult to, at least it feels difficult to justify why you need these employees, especially when you're out on the floor and you see the problems, you see the lack of education and the lack of awareness. And then you try, it's hard to translate that at a higher level, even beyond our institution. And it would be so fascinating. It's hard to even find kind of what Amy was saying, information on, well, how many employees is acceptable for the amount of beds that our hospital has. That kind of information would be so helpful. And that's what I called around to, we've acquired many facilities throughout the years, and I've called to their vascular access nurses to see what they're doing, and other neighboring institutions in our city, see how many employees they have and what their workflow is like. And then we kind of went from there. It's not, real data, which would be really helpful, but it's that raw data that you get from other people. I don't know if that
coming.
helps.
If
It's
only the
coming, yeah,
government could, thanks to Amy Barden and her team, but if only the government could see what we see on our daily rounds, I think it could change
Yeah.
quickly.
Mhm.
Yeah.
Right. So this is going to go out to Amy. First you, Jonathan, I want you to follow up. What's your primary criteria, or what do you look for when making a new hire? Amy, I know your answer, but I want others to hear.
So you hire for attitude and you train them to be successful, because you can make somebody very successful, but you can never change a bad attitude. And you have to have such a good attitude with great big shoulders to take on the momentous task that Jonathan has outlined here, to showcase, to build, to tell the story, to be passionate and dedicated, and to maintain an energy level when everybody says no. So always hire for attitude.
Yeah, it's so true. We've put job postings up for our positions, and as many of you know, there's not many of us out there. So number one, it's going to be hard to find someone with experience, but at the end of the day, what matters is that attitude, because we are kind of the gatekeeper. We make those decisions on what is the right line to be placed, and if it's the and you have to really put your foot down a lot of times, because the ordering teams positions might want something. Just because they want it doesn't mean it's appropriate, and you have to have the proper knowledge, and that to be able to explain to them why this is the appropriate line. And I think that's really the way around, and it doesn't work. They don't
Thank
have
you.
that. Mhm.
For our IPs that joining this talk, you guys don't get off too easy here. Bringing you in. What the value that you have found by collaborating with your vascular access specialist? Can you weigh in here about how that's helped you, how that's helped your hospital, and how we can get more IPs and vascular access teams to collaborate better?
Well, I'll start, and then Marissa can chime in. Marissa, I know, worked really intimately with Jonathan, and currently in the enterprise role, we're utilizing Jonathan's expertise a lot in our trying to standardize some practices across multiple hospitals. And I can't say enough for the relationship that we've been able to develop. It's been really helpful, and I think it is important to try to engage infection prevention in this journey, because they do have, they can definitely be a good support system. And obviously, we're researching these cases, we're looking at them, we're trying to identify what are the initiatives that we can put in place. So I think that, trying to engage your infection preventionists and explaining to them, maybe they don't have a full understanding. I think it was mentioned earlier, like they may not understand what the team does and the benefit. So I think, having your vascular access team and infection prevention on the same page is helpful. And like I said, for us, it really was, it has been a journey, but the group together has been very aligned and strong. Marissa, I don't know if you want to add, because you worked very closely with Jonathan on the CLABSI team at Jefferson.
Yeah, I mean, I would like to add that I learned a lot. I'm not a nurse. I don't have that background. I'm a microbiologist with a master's in public health, and then I went into infection preventionist. So I'm expected to be the expert, though, in CLABSI prevention. when I didn't know what was happening on that bedside because I didn't have that nursing background. So, Jonathan really showed me everything. I mean, I've watched him, I've gone in rooms with him and watched the insertion, and I saw what it took and what we really needed to focus on as infection preventionists. So I was able to get that background without actually, being a bedside nurse in the past. And it's a really great partnership. And I think that infection preventionists should really do this with all positions throughout a hospital, have that relationship with physicians and nurses. I mean, we talk with physicians too, about the access, not just with, Jonathan's team. It's also speaking with the attendings. And we just need to be collaborative. And that's everything that we do in a hospital, right? We need to be collaborative with all the teams. But I just learned a lot. And now I feel confident when I tell people this is what we should be doing. So I really appreciated that from Jonathan.
I think I
agree
have
with
your
Marissa.
counterpart as part of our board of directors, Marissa. So another non-nurse, infection preventionist, epidemiologist with a master's in public health. So you guys need to team up, I think.
Yes, very, very much so.
It's wonderful to have you, by the way. So I'm so glad you're here. So let me go back to Jonathan. One of our listeners is asking what's the size of your hospital? And congrats on getting the 5 FTEs at one go.
I know. Tell me about it. What I think, Kelly, what we have, was it 850 beds? I would have to go back and look at it.
It's 920.
900. Yeah.
Oh,
900, over 900.
Yeah. So, we also cover, so our hospital, we have another hospital down the street. It's like a block away, and that includes that number includes those beds as well. And then we have Methodist Hospital down the street. But so I'm in more of the Center City division, even though I look over the Methodist division a few miles down. But that hospital of neuroscience, which is where a lot of our stroke patients are, we cover that. So it can be a challenge a lot of times, especially when we were just 1.5 FTEs going to that facility, because you literally have to pack a bag and go to another hospital and find an ultrasound, and it's kind of crazy. So now, we'll have those employees to do that. We might have a couple patients there a day, and then also, we got our own ultrasound for that hospital, which expedites the process so much easier. So we made a lot of great changes.
I did want to say one thing that I think was helpful is that for infection control, we were able to support Jonathan. What he's mentioning is helping to put in place that we needed to get additional supplies. And we were able to be a voice for him to get those things that he needed to be able to move it forward, because, having a seat at the table saying these are preventing infections, these are helping the patient. So that collaboration, I think, was really important. I remember many conversations trying to get additional supplies needed for his team.
Yeah, I remember the cell phone. He didn't even have
that's
a
what I
cell
remember
phone
too.
for physicians to call.
Yeah, we had a pager.
And I was like, he needs one now. Please get him a phone today.
Yeah.
You guys are amazing. This has been wonderful. I have one last question/statement, and then we're going to move to giving you the CE code, guys. So one of our listeners, she is an infection preventionist, non-nurse, and she too just recently passed her VABC exam. So congratulations, Luz. And she is saying she cannot recommend enough the exam for the infection preventionist. It's absolutely worth it. It really strengthened my relationship with our vascular access team. So all you IPs out there, vascular access board certification is not just for inserters. It's for everybody involved. So we really do think that you're part of us. You're kind of the jelly to our peanut butter. So we belong together. So I want to thank you all for this amazing presentation. This does end the CE portion of our program. Be sure to write down the CE code that you see on the screen. And we ended it earlier. Gosh, I read the wrong part. But thanks for joining us. We'll have a quick break, grab a snack, and I'll meet you back here at 12:30 Eastern. Thanks, guys.